you discussing about preeclampsia and FGR using the simulation way. So this simulation way is an innovative way of depicting the conversations between radiologists and gynecologists and between radiologists and patients. The cases that will be presented here are of FGR and preeclampsia that are delivered prematurely, and these will be narrated by Dr. Kavita Aneja ma'am. Dr. Kavita Aneja is a radiologist practicing in Rohini, Delhi, and she is the radiologist who has actually scanned the patients. Ma'am is the national core member and state coordinator for Samrakshan and is also a reviewer for multiple index journals. She has been an executive member for IUFUMB and attended multiple conferences with awards. Dr. Vandana Sanwalka is an obstetrician and gynecologist practicing in Delhi. She is a senior consultant in Navjeevan Hospital, Delhi, and she will be enacting the role of the gynecologist of the patient. The clinic staff, including Mrs. Sangeeta, Shivani, Simran, and Faisal, who have been working continuously as the Samrakshan Task Force, have acted as the patients and also done the editing and the cinematography part. I would like to welcome our National Coordinator, Dr. Lalit Sharma, practicing in Guna, National Academic Lead for Preeclampsia, Dr. Shilpa Satarkar ma'am from Aurangabad, National Joint Coordinator, Dr. Gulab Chajed from Sumerpur, Founder Samrakshan, Dr. Riju Matthew from Kochi, Dr. Akansha Baghel, Harda MP Samrakshan Coordinator. This event has been coordinated or organized by Dr. Akansha Baghel and Dr. Ramesh Sonoy, sir. I welcome you all. Now I would like to hand over to Dr. Kavita Aneja ma'am.
Thanks for kind words, Dr. Kriti, and good evening, everyone. Many thanks to Samrakshan IRIA for this opportunity to present FGR and preeclampsia the simulation way. Can I share my screen? Is my screen visible, Kriti?
Yes, ma'am, your screen is visible. We can see your first slide.
And I'm audible, right?
Yes, ma'am, you're audible.
So preeclampsia and FGR the simulation way. I'll be putting across some messages through Simulation Act by Samrakshan Yodhas. And this is a conversation, day-to-day conversations that we have in our clinic. So before I come to the case, let's have some facts there. So India contributes to 25% of the world's statistics as far as adverse pregnancy outcomes are concerned, and the adverse outcomes are low birth weight babies, stillbirth, perinatal mortality, neonatal and infant mortality. And as much as we talk of aneuploidies, we are only looking at the tip of the iceberg. The major chunk of adverse pregnancy outcome arises from hypertensive disorders in pregnancy, which accounts for 10 to 12% of the population, preeclampsia, which is 8 to 10%, and low birth weight and FGR, which comprises of 30% to 40% of Indian population. So we categorize hypertensive disorders in pregnancy into 4 categories: chronic hypertension, gestational hypertension, preeclampsia, eclampsia, and chronic hypertension with superimposed preeclampsia. These disorders are among the leading causes of maternal and fetal morbidity and mortality, and a proper diagnosis is crucial in order to initiate appropriate treatment. What is gestational hypertension? Blood pressure of 140/90 detected beyond 20 weeks of gestation that returns to normal within 42nd postpartum day. So it's blood pressure happening after 20 weeks, high blood pressure after 20 weeks, which returns to normal about 1.5 months after delivery. Chronic hypertension is a known case of hypertension or pre-gestational hypertension, a case of hypertension detected before 20 weeks of gestation. Preeclampsia is a multi-system inflammatory disorder beyond 20 weeks of pregnancy with significant proteinuria, characterized by de novo onset of hypertension. That means hypertension starts beyond 20 weeks and it is accompanied by proteinuria. And then we have atypical variant of preeclampsia, wherein there is absence of proteinuria, but hypertension is accompanied by neurological, hematological, hepatic, and renal manifestations. Eclampsia is occurrence of seizures in association with preeclampsia. Superimposed preeclampsia is occurrence of preeclampsia in women with chronic hypertension. Blood pressure reading should be reconfirmed after 4 to 6 hours before classifying a patient in a particular group. And with this, I come to my case presentation.
मैम पेशेंट रूबी को लियो।
हाँ भेज दो, अंदर भेज दो।
गुड मॉर्निंग मैम।
गुड मॉर्निंग, बैठो।
मैम मेरा नाम रूबी है और एक्चुअली मैंने पीरियड्स मिस हो गए थे तो मैंने घर में ही प्रेगनेंसी टेस्ट कराया था जो कि पॉजिटिव आया और 2 महीने की प्रेगनेंसी है और 36 ईयर्स मेरी एज है।
गुड। रूबी, मुझे याद आ रहा है शायद पहली प्रेगनेंसी में भी आप मेरे पास आए थे। आपका ब्लड प्रेशर हाई था और फिर आपकी प्री मैच्योर डिलीवरी हो गई थी किसी गवर्नमेंट सेटअप पे।
मैम बेबी 34 वीक्स में ही हो गया था और NICU में 1 हफ्ते के लिए एडमिट था।
तो अब कैसा है बच्चा?
तो मैम बेबी ठीक है, 3 साल का हो गया और हेल्दी है मैम।
गुड। अब ऐसा है रूबी, क्योंकि इस प्रेगनेंसी में भी ऐसा हो सकता है, इसलिए हम इस बार बहुत केयरफुल मॉनिटरिंग, स्पेशल टेस्ट एंड स्पेशल अल्ट्रासाउंड करेंगे आपके, जिससे कि ये प्रेगनेंसी आपकी ठीक रहे। तो मैं आपको बुलाती हूँ अभी, आप बाहर बैठे, मैं बुलाती हूँ।
थैंक यू।
On physical examination, the blood pressure of the patient was normal, 120/80. BMI was on the higher side. It was 40.2 kg per meter square.
Hi, Dr. Kavita. I'm Dr. Vanna here.
Hi, Dr. Vanna. So nice to hear from you after such a long time.
Yes. Actually, the patient turnover is less these days. Dr. Kavita, I called you regarding patient Ruby. She is 36 years old, who's here with me for her second pregnancy. If you remember, she had come to me with hypertension in her 7th month of pregnancy, and she was scanned by you. You had scanned her in the 7th month and informed me about the FGR and to monitor her for PE. But we lost her to follow up, and she delivered at 34 weeks of pregnancy in some government setup. Baby was admitted in an ICU for a week or so, but now baby is healthy and fine. Now her BP is normal, but she is obese, so I am starting her on her tablet EcoSpring 75 milligram at bedtime because of her characteristics and previous history. Now you should tell me, how do you suggest a follow step this time?
Okay. Dr. Vanna, I discreetly remember this patient, Ruby. She had gestational hypertension in her second half of pregnancy. And she had probably come to me at 28 weeks and I had scanned her and it was FGR and abnormal Dopplers. In fact, I asked her to come after 1 week, but she never turned up. And now you say she delivered premature at 34 weeks. Anyways, just send her to me in between 7 and 10 weeks for viability scan and to check, do I need to change her LNP, if the gestational age by ultrasound is corresponding to GA by LNP or not, and I will see the cardiac activity as well. Okay. So let me see her at 7 to 10 weeks and then let's follow her very closely for hypertension and any complications.
Okay, I'll send her to you. Okay.
Okay, bye.
Bye.
According to FOXI guidelines for aspirin in hypertensive disorders in pregnancy, low-dose aspirin has a good maternal and fetal safety profile. Aspirin tablets 75 milligram are readily available and easiest to prescribe. Aspirin for hypertensive disorders in pregnancy should be started even earlier than 12 weeks. Early aspirin balances the levels of thromboxane, A2, and prostacyclin, which will maintain adequate uteroplacental blood flow and improve placentation. Therefore, it appears safe to use low-dose aspirin as a prophylaxis to prevent preeclampsia throughout pregnancy until 2 days prior to delivery or cesarean section. According to ACOG committee opinion, low-dose aspirin 81 milligram per day, in India it is 75 milligram, is recommended in women at high risk of preeclampsia and should be initiated between 12 weeks and 28 weeks of gestation, optimally before 16 weeks, and continued daily until delivery. Low-dose aspirin prophylaxis should be considered for women with more than one of several moderate risk factors for preeclampsia. And as for the risk factors, we have this risk scoring by United Kingdom and United States, which is similar and established practice throughout the world, although we know it is ineffective and we need to add biophysical and biochemical markers. But before 12 weeks, we can go by the risk scoring system, which has a 40% detection rate. So in this particular patient, we had two moderate risk factors, which were age more than 35 years. She was 36 years old and BMI was more than 30 kg per meter square. And she had gestational hypertension in her previous pregnancy.
रूबी, आपको मैं डॉक्टर कविता के पास भेज रही हूँ। वो ये चेक करेंगी कि जो तुम अपनी लास्ट मेंस्ट्रुअल डेट बता रहे हो उसके हिसाब से तुम 8 वीक्स 2 डेज प्रेग्नेंट हो या नहीं, वेदर इट इज करेक्ट और नॉट। और वो ये भी देखेंगे कि बच्चे की दिल की धड़कन है और ठीक है। ठीक है, तो आप डॉक्टर कविता के पास जाओ, स्कैन करो। थैंक यू डॉक्टर।
मैम नेक्स्ट रूबी अल्ट्रासाउंड के लिए गया पेशेंट रूबी जिनके डॉक्टर ने कॉल करा। यस मैम। हाँ गुड मॉर्निंग रूबी, आपके लिए कॉल आया था डॉक्टर साहब। सो ये आपका प्रिस्क्रिप्शन है मेरे पास रूबी। यू आर 36 ईयर्स के हो गए आप और आज आपके 8 वीक्स हो गए। तो आपका प्रीवियस प्रेगनेंसी में आपकी हिस्ट्री में देख रही हूँ, आपका प्रीवियस प्रेगनेंसी में ब्लड प्रेशर ज्यादा हुआ। कौन से मंथ में ज्यादा हुआ? 5th मंथ के बाद हाई होना शुरू हुआ और आप मेरे पास एक ही अल्ट्रासाउंड के लिए आए थे। तो ये जो अल्ट्रासाउंड आपका हुआ ये 28 वीक्स में लिखा हुआ है। आप 7th मंथ में आए थे और उसमें डॉप्लर्स एबनॉर्मल थे, बच्चा वीक था, ग्रोथ रिस्ट्रिक्टेड था और आपको 1 हफ्ते के बाद मैंने बुलाया था।
एक्चुअली घर में कोई पर्सनल इशू हो गए थे तो मैं आ नहीं पाई और नेक्स्ट मंथ मेरी डिलीवरी हो गई थी।
अच्छा,
और बेबी
नेक्स्ट मंथ आपकी डिलीवरी होगी 34 वीक्स की। तो बेबी का वेट कितना था? 1.4 kg। NICU में आया कितना टाइम?
7 दिन तक ICU में रहा।
अब ठीक है?
अभी नॉर्मल सब कुछ ठीक ठाक है। मैं
तो नॉर्मल डिलीवरी थी। अच्छा, तो पेन्स हुए थे क्या?
वाटर फॉल हो गया था।
अच्छा, रप्चर ऑफ मेम्ब्रेन था। हाँ, वाटर लीक हो गया था इसलिए डिलीवरी हुई। और ब्लड प्रेशर आपका लिखा हुआ है 140/90, इतना ही रहा? इससे ज्यादा तो नहीं हुआ। और डिलीवरी के बाद बीपी नॉर्मल हो गया था?
हाँ जी, 1 मंथ बाद मेरे बीपी नॉर्मल।
1 मंथ के बाद बीपी नॉर्मल। तो ये 3 साल का बच्चा अब आपका है, तो 3 साल बीपी नॉर्मल रहा। अच्छा, तो रूबी पिछली प्रेगनेंसी में जो बीपी हाई था तो क्या तुम्हारे हाथ पैर में सूजन आई थी? नहीं। और सिर में दर्द रहता हो या पेट में दर्द रहता हो, ऐसा कोई सिम्टम नहीं था? तो सिर्फ बीपी हाई था और यूरिन में प्रोटीन कुछ अगर तुम्हें ध्यान हो, यूरिन टेस्ट हुआ, प्रोटीन आया हो, ऐसा कुछ?
इसका तो कुछ याद नहीं, मैं 3 साल पहले ही वाला तो कुछ याद नहीं
करा भी था कि नहीं करा था। तो इन इन ऑल प्रोबेबिलिटी तुम्हारी पिछली प्रेगनेंसी में तुम्हें जेस्टेशनल हाइपरटेंशन था, यानी कि हाइपरटेंशन जो कि प्रेगनेंसी में होता है और जिसमें कि प्रोटीन यूरिया या और कोई कॉम्प्लिकेशन नहीं होती, सिर्फ हाइपरटेंशन होता है जी। ठीक है। तो भी आपकी गायनेकोलॉजिस्ट ने जो डायग्नोसिस आपका लिखा हुआ है हाइपरटेंसिव डिसऑर्डर इन प्रेगनेंसी, इसका मतलब है कि प्रेगनेंसी के दौरान आपका बीपी लास्ट टाइम बढ़ा था और आज का बीपी आपकी गायनी ने नॉर्मल लिखा हुआ है जी। तो 75 मिलीग्राम इकोस्प्रिन आपको स्टार्ट की है, आप ले रहे हैं, शुरू कर दिया। ठीक है, तो अल्ट्रासाउंड करके देखते हैं कि आपका 8 वीक्स जो डेट के हिसाब से है अल्ट्रासाउंड में कितना आ रहा है। ठीक है, तो इनका बीपी ये आज का बीपी है आपका 120/80 हमारे यहाँ पर, और आपकी गायनी ने भी इतना ही लिखा हुआ है। और हाइट एंड वेट के हिसाब से जो आपका BMI आपका ओबीज कैटेगरी में आ रहा है, तो वेट थोड़ा ज्यादा है। चलो, इसीलिए आपकी गायनी ने आपको एक इकोस्प्रिन की गोली स्टार्ट करी है। इनको ले लूं अल्ट्रासाउंड के लिए। आइए, तो आपने बताया कि आपकी डेट आपको कंफर्म है, LMP कंफर्म है और पीरियड्स रेगुलर आते थे। अच्छा, तो आपका बच्चा नॉर्मल जगह पे है, यूट्रस के अंदर है और हार्ट बीट आ गई है, नॉर्मल हार्ट बीट है। ग्रोथ बच्चे का साइज जो है वो उतना नहीं है जितना आपका LMP बता रहा है, तो मैं आपको एक नई LMP दूंगी। ठीक है, तो आपको आगे के लिए याद रखनी है।
So, gestational age by ultrasound was 7 weeks and it was 9 days behind GA by LMP. A new corrected EDD gestational age and a revised calculated LMP was given to the patient and counseling done that for all future scans, she should be quoting this new LMP now, and she should forget about her old LMP. Cardiac activity was present and the report was discussed with the gynecologist and patient advised to come at between 12 and 13 weeks for NT scan. So when do we redate the pregnancy? We redate a pregnancy when discrepancy between gestational age by LMP and GA by ultrasound is more than 5 days before 9 weeks, or more than 7 days between 9 and 16 weeks, or more than 10 days between 16 and 22 weeks. If the pregnancy has not been dated till 22 weeks, we call it inadequately dated pregnancy. But if we have to date, we do 2 scans 3 weeks apart and then assign the EDD.
Hello. Hi, Dr. Vandana. Dr. Kavita here. So your patient Ruby, she just came to me for viability scan. Dr. Vandana, she is 7 weeks live intrauterine pregnancy and there is a discrepancy of 9 days in gestational age by ultrasound and GA by LMP. So I have corrected her LMP. I have given her a revised LMP and I have given her the corrected EDD and gestational age. So please send her to me at 12 to 13 weeks, in between 12 and 13 weeks by this new LMP now. And I'll do her NT scan. And we will also do a combined screening at that time with double marker and NT. And I would also suggest you could add ENGF to combined screening because her pre-eclampsia risk assessment we need to do this time.
Okay, Dr. Kavita, was there a need to change the LMP? Patient was very sure of her dates. And what if we do NIPT on her instead of doing NT scan and combined screening, as she is more than 35 years old and NIPT is a better test. It gives 99% accuracy for Down syndrome.
You're right, Dr. Vandana, NIPT is a good test. To begin with, I will like to tell you why I have changed her LMP. Actually, the discrepancy I told you between GA by LMP and the GA by ultrasound is more than 7 days. And by protocol, in such cases, we need to change the LMP, because for all future scans, we need to know the precise gestational age. And how else will you know when to send her for NT scan, when is her 12 weeks? Because if you send her at 11 weeks, I will not be able to do a proper structural anomaly scan. And if you send her to me at 14 weeks, the fetus, it becomes vertical and it's difficult to look at the NT. So I need precise 12 and 13 weeks, between 12 and 13 weeks. And so we need a correct gestational age right in the first trimester, right in the first viability scan. So I have corrected the date. And also, now we talk in terms of percentiles of biometry and percentiles of color Doppler. And if gestational age is wrong, all these percentiles which are GA dependent, all of them will be wrong, and either we will overdiagnose FGR or we will underdiagnose FGR. And also for precise time of delivery, I would say we need a very correct LMP, and we need to know the correct gestational age, because we don't want to deliver too early or too late. So I have changed the LMP in this case. And regarding NT scan, it is not only for Down syndrome. We need to do an NT for structural anomalies, and then if at all there is some suggestion of some anomaly, or if the risk by combined screening is in intermediate category, in those cases we will do an NIPT. Okay? So not straight away NIPT. So please send her to me between 12 and 13 weeks, and at that time I will also do preeclampsia and FGR screening to know her risk of preeclampsia. You know, she was a hypertensive in her last pregnancy as well.
I will write the patient accordingly.
Okay, bye-bye.
So this is just another case scenario. This patient came to me at 27 weeks and 5 days by her LMP, and on biometry, all the parameters were at 5 centile. The weight was also 5 centile. So she was small for gestational age because weight and AC were below 10 centile. So before labeling her as GA baby, because she had come to me for the first time at 27 weeks and 5 days, I insisted on the first trimester reports. And luckily, the patient had 2 reports, the viability scan and NT scan reports with her, and both of them showed a discrepancy of 1 week between GA by LMP. GA by ultrasound was 1 week behind, but the date had not been corrected. The LMP had not been corrected at that point in time. So I corrected this LMP. So 2nd of November, I made it 9th of November, and look what happened to the biometry. So all the biometry now falls in AGA category. Now this baby is an AGA appropriate for gestational age baby with weight at 24 centile. So always insist on first trimester scan reports to check for dating, to check if the date has been corrected, or is it the correct LMP which you have with you. Discordant dating of pregnancy by LMP and ultrasound and its implications in perinatal statistics. This is an article published by Samrakshan in IJRI mentioning a dating discrepancy which leads to perinatal mortality. And about NT scan, we all are aware that it it is a comprehensive scan, which includes chromosomal markers, assessment of chromosomal markers, NT-NP, TVTR, anatomical survey, and diagnosis of multiple gestation, fetal environment. And now we insist on prediction of preeclampsia and FGR by Samrakshan and FMF protocol, which is the same, and initiation of ecosprin for all those who are at high risk. Biochemical screening for aneuploidies and adverse pregnancy outcome is done by combined screening. We all know it is history, NT, free beta HCG, and PAPE. PLJ may be added if we have, if we want to rule out preeclampsia in this screening. And if the screening result is intermediate, we will like to do an NIPT on her. And if there is a structural anomaly, we go in for invasive testing. And a low beta HCG PAPE and low PLGF are indicative of adverse pregnancy outcomes. So now this patient did not come to me for her NT scan. She went to some other center and she went at 13 weeks, 5 days. So despite insisting that the next scan should be done between 12 and 13 weeks, patient went to some other center at 13 weeks and 5 days. And blood pressure was fortunately done at this scan, this center, and it was 138/90. So this was the first time a high blood pressure was noted in this patient. GA by ultrasound was 13 weeks, 2 days, so a lag of 3 days, and there was no anomaly, no genetic marker, but the uterine artery PI, the mean PI was 95 centile. Now, screening for preeclampsia and FGR was not done in this center, and the patient and gynecologist were not alerted by the radiologist. Follow-up scan was advised at 19 to 20 weeks, but patient continued with tablet ecosprin 75 milligram, which was initiated at 8 weeks by the gynecologist. It's a good practice to record BP on every visit at ultrasound centers as well, but it is not a good practice not to do screening for preeclampsia and FGR in the first trimester. A couple of slides on uterine artery PI. So we know in the first trimester, we interrogate the uterine artery at uterocervical junction, and it is the arising ascending course where we interrogate the vessel. And anything above 95th centile PI is a high resistance. So what is important is the detection rate for early onset preeclampsia, that is before 34 weeks, by uterine artery PI alone is 48%, and for late onset preeclampsia after 34 weeks, it is 26%. Now, this is a meta-analysis published in the White Journal in 2014. It is performed on 56,000 women, first trimester uterine artery Doppler and adverse pregnancy outcomes. And this reveals that only 48% cases of early onset preeclampsia will be detected if we go by uterine artery PI alone. So we are going to miss 52% of the cases which could develop preeclampsia. And only 40% of cases of early FGR would be detected by uterine artery PI alone. Therefore, given the low sensitivity, clinicians and mothers need to be aware of the possibility of not identifying women who may develop early onset preeclampsia later in pregnancy if you do the screening by uterine artery PI alone. So what should have been done? Screening for preeclampsia and FGR should have been done by complete FMF protocol, which is also the Samrakshan protocol, which is a 5-step approach. So we take the maternal history, we take mean arterial pressure, uterine artery PI on the 2 sides, and take the mean. And biochemical screening may be added to this triple screening, and we calculate this patient-specific risk. And this is how it is done. So go to the FMF calculators, and click on the first trimester screening, put in the maternal characteristics and the history there, the mean arterial pressure from both arms, the 2 readings 1 minute apart, uterine artery PI, both the values, and we calculate the risk. Biochemical measurements can be added. Now, according to FMF, the detection rate for preeclampsia before 34 weeks, that is early onset preeclampsia, is 90% by this screening, which is the quad screening by history, mean arterial pressure, uterine artery PI, and PLGF. And even if we skip PLGF, we do only triple screening with maternal factors, MAP and uterine artery PI, we have a decent detection rate of 80% for early onset preeclampsia before 34 weeks. And this is what Samrakshan insists on, screening by triple parameters, maternal factors, MAP, and uterine artery PI for all women who come to the clinic. And this should be conducted pan-India. And so after this screening, if the risk is more than 1 in 150, we call it a high risk, and we initiate tablet ecosprin 150 milligram HS right there at 12th week in the first trimester, and we continue this till 36 weeks. Even if it is a low risk, we need to calculate the risk again at 22 weeks. So both high risk and low risk do the screening again at 22 weeks. Now, aspirin should be started before 16 weeks for all high risk patients by first trimester screening, because placentation is almost complete by 16 weeks. Now, this patient came to me at 19 weeks for her level 2 scan. Blood pressure was 136/90, almost the same as it was in the first trimester, and mean arterial pressure was 97 millimeter of mercury, which is on the higher side. Patient was taking ecosprin 75 milligram, and on interrogation, patient was taking ecosprin in the morning hours. No, she was on salt restriction, no antihypertensives added so far. On ultrasound, GA by ultrasound was 18 weeks, so a lag of 1 week was there. Uterine artery PI was borderline high. It was at 90 centile. No anomaly, no genetic marker. LICA was normal. Risk for preeclampsia was calculated by FMF and Samrakshan, and it was 1 in 25. And the patient and gynae were now alerted about the high risk. Biometry was normal till now. So the only positive finding was a higher uterine artery PI. It was borderline high. So although there was a lag of 1 week, please don't change the LMP or EDD. Once assigned in the first trimester, don't change LMP, EDD again in the pregnancy. Now, this screening was done by the same method as it is done in the first trimester. Again, the 5-step approach. And how do we do the mean arterial pressure? BP is taken by automated device simultaneously in both arms, women in sitting position, legs uncrossed. Arms should be supported at the level of heart and adult cuff used. After rest of 5 minutes, 2 sets of measurement taken 1 minute apart simultaneously on both sides are recorded and put in the software, which calculates the mean arterial pressure. Unsupported arm, unsupported back increases the diastolic blood pressure, and crossing the legs increases the systolic blood pressure. Now, there are common positioning problems that can lead to inaccurate. This is how we should be taking the BP.
आपको ये इसका प्रेशर तो नहीं है? आपका 2 बार BP लेंगे 1 मिनट के गैप में। आपको बोलना नहीं है, ठीक है?
So that is the correct technique of taking mean arterial pressure. Unsupported back of feet, crossed legs, unsupported arm, full bladder, cuff over clothing, cuff too small, talking or listening. All these lead to inaccurate BP measurements, and the reading may be off by 5 to 10 millimeters of mercury. And we know how to take uterine artery PI in the second trimester. It is at the apparent crossover of uterine artery with external iliac vessels. It is taken as proximal as possible before the uterine artery gives off a branch. It can also be done by transvaginal method, similar to what we do in the first trimester. And the readings are seen. We see the PI, the percentile of the PI. By putting the reading in uterine artery nomograms. So we have it all over. And then we go to FMF calculator and we click on the second trimester screening here and fill in the characteristics and the history, fill in the values of the blood pressure that we have just taken, the uterine artery PI from both sides, and we calculate the risk. Now, why do we need to fill samrakshan forms? Like I said earlier, that we have a cutoff of 1 in 150, beyond which we call it a high risk, and we initiate eco-sprint. So where does this 1 in 150 come from? This is the cutoff given to us by FMF for Asian population, but FMF is a UK body. Ironically, India has 5 times more preeclampsia and FGR than the West. And we are following the protocols and the cutoffs given to us by the West. And that is where we need our own cutoffs, our own guidelines. And the research wing of Samrakshan is working relentlessly for this under the leadership of Dr. Praveen Nirmalan. And so every time we do a scan, we need to fill in the form and submit at the Samrakshan website. This is IRIA, go to program and then Samrakshan and Samrakshan forms, and you have trimester specific forms there. And we can also download a Yoda Excel sheet from this block here. And this data is then analyzed by the research wing of Samrakshan, headed by Dr. Praveen Nirmalan. And this is how we can contribute to the research and we can contribute to the cause.
तो रूबी, हमने अभी आपका लेवल 2 स्कैन करा, ठीक है, जिसमें कि हम बच्चे के बॉडी पार्ट्स देखते हैं सब, और साथ ही में हमने स्क्रीनिंग करी। आपने देखा, हमने आपका ब्लड प्रेशर लिया, हमने अल्ट्रासाउंड में कलर डॉपलर करा, जिससे कि ब्लड फ्लो माँ से बच्चे को कैसा जा रहा है उसके बारे में हमने देखा, और आपकी हिस्ट्री ली, हाइट और वेट लिया, इन सब से हमने स्क्रीनिंग करी आपकी। ये स्क्रीनिंग थी प्री एक्लेम्सिया के लिए और फीटल ग्रोथ रिस्ट्रिक्शन, कितना चांस है आपका आगे जाके प्री एक्लेम्सिया होने का, बच्चे के कमजोर होने का, ये सब इस सब के लिए हमने आपका ये स्क्रीनिंग करी है, ठीक है। अब अल्ट्रासाउंड में आपका बाय डेट्स बाय LMP 19 वीक्स होना चाहिए था, पर 18 हफ्ते आया, यानी कि 1 हफ्ता कम आया। पर आपके बच्चे की बनावट, आपके बच्चे के बॉडी पार्ट सब नॉर्मल है, ठीक है। अब जो ब्लड फ्लो हमने देखा, तो मदर से बच्चे को जो ब्लड फ्लो जाता है वो कॉम्प्रोमाइज है, वो कम जा रहा है, और आपका ब्लड प्रेशर थोड़ा हाई की तरफ है, ठीक है। आज 135/90 आया है आपका बीबी। तो इन सबसे जो हमने स्क्रीनिंग करी है उसका रिस्क ज्यादा है, ठीक है। तो देखते हैं आपका रिस्क, इनका मुझे रिस्क, तो ये हमारा रिस्क असेसमेंट है, और ये हम करते हैं FMF प्रोटोकॉल, यानी कि जो हमारी वर्ल्ड की फीटल मेडिसिन फाउंडेशन, जिसको कि हम संरक्षण, यानी कि जो इंडिया का रेडियोलॉजिस्ट की बॉडी है संरक्षण, हम भी इसी को फॉलो करते हैं, ठीक है। तो ये प्रोटोकॉल के साथ हमने आपकी स्क्रीनिंग करी है, और आपका रिस्क इसमें आया है 1 in 25 बिफोर 36 वीक्स, यानी कि 36 वीक से पहले प्री एक्लेम्सिया होने का आपका रिस्क है 25 में से 1, ठीक है। ये काफी हाई रिस्क होता है। तो FGR रिस्क में
नो मैम सेकंड ट्राइमेस्टर रिस्क नहीं है।
हाँ, तो अगर यही स्क्रीनिंग हमने फर्स्ट टाइम करी होती जब आपने अल्ट्रासाउंड एंटी स्कैन कराया दूसरे सेंटर में, तो हमारे पास प्री एक्लेम्सिया रिस्क के साथ FGR रिस्क भी आता। ठीक है, तो सेकेंड ट्राइमेस्टर में यानी कि 20 वीक्स पे FGR रिस्क नहीं आता, सिर्फ प्री एक्लेम्सिया रिस्क आता है। तो आप मुझे बता सकते हो इतना 1 in 25 इनका इतना हाई रिस्क क्यों आया?
जी मैम एक जन की एज 36 है मैम, तो सेकंड BMI ज्यादा है इनका, क्रोनिक हाइपरटेंशन
यस है।
तो मैम मैथ रैंक 97 और यूटर्न आर्टरी है 90 सेंटाइल। और मैम इनका लास्ट प्रीवियस हिस्ट्री है हिस्ट्री ऑफ प्रीमेच्योर डिलीवरी।
तो फिर आपका जो रिस्क हाई आया है इसके रीजंस हैं आपकी एज 36 इयर्स, आपका BMI, आपका वेट ज्यादा है, हाइट कम है इसलिए आपका BMI हाई है, आप साउथ एशियन हैं विच इटसेल्फ इज अ हाई रिस्क, क्रॉनिक हाइपरटेंशन, आपको जो इस बार ब्लड प्रेशर हुआ वो 3rd मंथ से हो गया। ठीक है, तो और हिस्ट्री आपकी पिछली बार जेस्टेशनल हाइपरटेंशन, तो ये क्रॉनिक हाइपरटेंशन नहीं था, ये जेस्टेशनल हाइपरटेंशन था लास्ट टाइम। एनीवेज इस बार आपको हाइपरटेंशन क्रॉनिक हाइपरटेंशन की कैटेगरी में आता है क्योंकि आपका 5th मंथ से पहले से इस बार ब्लड प्रेशर हाई हो गया है। मीन आर्टेरियल प्रेशर जो कि हमने दोनों हाथ में आपका BP लिया था, 4 रीडिंग्स ली थी 1 मिनट के अंतर पे, वो भी ज्यादा की तरफ है, 97 है। ठीक है, अपर लिमिट 100 होती है तो ये ज्यादा की तरफ है। यूट्राइन आर्टरी PI 90% है और प्रीवियस हिस्ट्री ऑफ प्रीमेच्योर डिलीवरी, तो कुल मिला के ये सारे रिस्क फैक्टर्स मिला के आपका रिस्क फॉर प्री एक्लेम्सिया 1 in 25 विच इज अ हाई रिस्क। और डबल मार्कर की मैं रिपोर्ट देख रही हूँ, ये क्रोमोसोमल एब्नॉर्मैलिटी के लिए लो रिस्क है, 1 in 10,000 है विच इज द लो रिस्क, पर PLGF आपका कम है। जो एक पैरामीटर हमने ऐड किया था, मैंने आपको कहा था डबल मार्कर में PLGF ऐड करना, तो PLGF आपका कम आया है और इसमें भी प्री एक्लेम्सिया का रिस्क ज्यादा है। ठीक है, तो ये जो हाई रिस्क ऑफ प्री एक्लेम्सिया है इसको देखते हुए जो रिकमेंडेशन, जो FMF की रिकमेंडेशन है वो है 150 मिलीग्राम इकोस्प्रिन। तो अभी आप ले रहे हैं 75 मिलीग्राम, आपको लेनी है 150 मिलीग्राम इकोस्प्रिन रात को सोने से पहले, और ये चलेगी आपकी 9th मंथ तक, 36 वीक्स तक चलेगी। ये इंफॉर्मेशन मैं आपके गायनेकोलॉजिस्ट को बताने जा रही हूँ। ठीक है, और अगर हम ये स्क्रीनिंग फर्स्ट ट्राइमेस्टर में कर लेते हैं, जो 12 हफ्ते वाला स्कैन आपका हुआ जो आपने कहीं और कराया है, तो हम ये 150 मिलीग्राम इकोस्प्रिन आपकी उसी टाइम शुरू करते हैं। ठीक है, उसका बेस्ट बेनिफिट होता है 16 हफ्ते से पहले शुरू करने का, पर क्योंकि वो नहीं हो पाई तो हम उसको अब शुरू करेंगे। ठीक है जी, अब आपका 19 वीक्स हो गया है। और नेक्स्ट जो अल्ट्रासाउंड है रूही, वो आप आएंगे मेरे पास 26 वीक्स पे। ठीक है, अभी आपका 19 वीक्स है यानी कि 7 हफ्ते बाद आएंगे। वैसे नॉर्मली मैं पेशेंट्स को 30 वीक्स पे बुलाती हूँ, पर आपको 26 वीक्स पे इसलिए बुला रही हूँ क्योंकि आपका प्री एक्लेम्सिया रिस्क काफी हाई है और आपका पिछली प्रेगनेंसी में 28 वीक्स पे जब मैंने अल्ट्रासाउंड किया था तो आपके डॉपलर्स एब्नॉर्मल थे और FGR हो गया था। ठीक है, इसलिए वो हमारा मिस ना हो इसलिए मैं आपको 26 वीक्स पे बुला रही हूँ। और इस बीच में यानी कि 19 हफ्ते से 26 वीक्स के बीच में आप रेगुलर ब्लड प्रेशर चेक करेंगे, हर हफ्ते आपका BP होना चाहिए और यूरिन प्रोटीन का भी चेकअप होना चाहिए। तो आप अपने डॉक्टर से पूछ लीजिएगा, अपने गायनेकोलॉजिस्ट से, कि यूरिन प्रोटीन कब कब कराना है। BP आप हफ्ते में एक बार जरूर करेंगे। ठीक है, और एक चीज और मैं चाहूंगी कि आपको प्री एक्लेम्सिया के क्या लक्षण होते हैं वो आपको मालूम होने चाहिए ताकि आप उस पर ध्यान रखें। जब भी कोई लक्षण प्री एक्लेम्सिया का सामने आए तो आपको अपने डॉक्टर को मिलना। ठीक है, तो एक हमारा छोटा सा ये प्रेजेंटेशन है जो कि प्री एक्लेम्सिया के लक्षण के बारे में है, ये आप समझ लीजिए। BP हाई होना 140/90 से ऊपर, यूरिन में प्रोटीन निकलना, या फिर स्वेलिंग ऑफ हैंड्स एंड फेस, ठीक है, हैंड्स, फीट, पैरों की स्वेलिंग, हाथों की स्वेलिंग, फेस की स्वेलिंग, हेडेक, सिर में दर्द होना, सडन वेट गेन, अगर आपका वेट एकदम से बढ़ता है, विजन में कोई चेंजेस, नजर में कमजोरी होना या स्पॉट्स नजर आना, ठीक है, स्टमक पेन, अगर राइट साइड अपर एब्डोमेन में पर्टिकुलरली हो तो उसका ध्यान दें, और नॉजिया एंड वॉमिटिंग, वॉमिटिंग की सेंसेशन, नॉजिया की सेंसेशन, ये सारे सिम्टम्स का आपने ध्यान रखना, ठीक है। और अब हम मिल रहे हैं 26 वीक्स पे, ठीक है।
थैंक यू डॉक्टर, आपने मेरे इतने अच्छे से अल्ट्रासाउंड किया और उससे मुझे डिटेल से बताया और प्री क्लैम्सिया और एचसीआर के बारे में मुझे बताया। मैं कल ही जाकर अपने डॉक्टर से रिपोर्ट्स शेयर करती हूँ।
Hello, Dr. Kavita.
Hi, Dr. Vanna. How are you?
Fine. Doing good.
So, this is regarding patient Ruby again. You know, she never came to me at 12 weeks.
Oh, she didn't come to me also after NT scan.
Oh, okay. So, now she has come to me today and she is 19 weeks by LMP. And by ultrasound, she is 18 weeks. So, there is a lag of 1 week, but that is not really, 1 week is not really important at this time. But her mean arterial pressure is 97 millimeter mercury, so it's on the higher side. And uterine artery PI is 90 percentile today. So I was just looking at her report, her NT report, which she did from some other center. Uterine artery PI that they have mentioned is 95 percentile. And today I'm getting it 90 percentile uterine artery PI in my scan at 19 weeks. There is no anomaly, Liker is normal. I've done her risk for preeclampsia by Samrakshan protocol, which is also the FMF protocol, and her risk is 1 in 25, which is a quite high risk for preeclampsia. And I'm looking at her double marker report also. This also shows the high risk for preeclampsia. Remember, we did a PNGF for her. So the report shows high risk for preeclampsia. Even the blood report shows.
Since uterine artery resistance is better now, Dr. Kavita, from 95 to 90%, so I think I can stop ecosprin and follow up her for room scan.
No. On the contrary, I would say that lowering of uterine artery resistance at the time of level 2 scan from level 1 scan itself indicates that ecosprin is working. But I would rather suggest you could increase the dose of ecosprin to 150 milligram HS, and this should be continued till 36 weeks. You know this, and this is according to Samrakshan protocol and FMF protocol for all high-risk patients, and this is a high-risk patient by the screening that I have done.
Is there any benefit of starting ecosprin 150 milligram at now 19 weeks? You used to say it is always better to start before 16 weeks.
Yeah, you are right. You are very right. I always told you ecosprin should be started before 16 weeks. But in this very patient, we don't have much choice. She never came to us. She didn't come to you. She didn't come to me at 12 weeks. And she's coming today at 19 weeks and still on 75 milligram ecosprin. I think we don't have a choice. We can start her on 150 milligram because still it will have 10% benefit if ecosprin is started after 16 weeks. If we could have started ecosprin at 12 weeks, it would have given us 80% benefit. But after 16 weeks, it is still 10% benefit. So, even for that much, I think we should start her on ecosprin. Rest decision is yours. And I would say she should be aware of signs and symptoms of preeclampsia. I have explained her all this signs and symptoms. So, maybe you could also tell her to be aware of the signs and symptoms. And please send her to me for growth scan at 26 weeks. Because in last pregnancy, she had abnormal Dopplers at 28 weeks. So it's, I think, wise to see her at 26 weeks this time and for her growth. And please see her closely for hypertension and proteinuria as well every week, since her preeclampsia risk is high and she's already hypertensive.
All right, I okay.
Oh,
So in the second trimester screening, if we have a high risk, we need to see these patients very closely between 24 and 31 weeks because preeclampsia starts after 24 weeks. For intermediate risk, we see directly at 32 weeks, and low risk we can see even later. So second trimester screening is basically to guide surveillance. If ecosprin has been started in the first trimester, we continue with ecosprin irrespective of the result of second trimester screening. Even if it comes out to be low screening, we continue with ecosprin. Even if uterine artery PI lowers, we still continue with ecosprin, which has been started in the first trimester. Second trimester screening only guides surveillance. If a patient is not on ecosprin already, if the screening is done for the first time in the second trimester, like in this patient, then we can start ecosprin 150 milligram at 20 weeks if the risk is high by this screening as happened in this patient. And regarding the dose of ecosprin, 150 milligram has advantage over 75 milligram. It has good bioavailability, better antithrombotic effect, and less resistance with a higher dose. At higher doses, aspirin inhibits both COX-1, COX-2, and this results in decreased platelet synthesis of thromboxane A2, which aggregates the platelets. This is another paper on ecosprin, role of ecosprin dose in prevention of preeclampsia and FGR, a meta-analysis on 21,000 women published in American Journal of Obs and Gynae. When aspirin was initiated at less than 16 weeks, there was a significant reduction and dose response effect for the prevention of preeclampsia and severe preeclampsia and FGR, with higher dose of aspirin being associated with greater reduction of the three outcomes. Prevention of preeclampsia and FGR using aspirin in early pregnancy is associated with a dose response effect. Low dose aspirin initiated after 16 weeks has a modest or no impact on risk of preeclampsia and FGR. Therefore, women at high risk for those outcomes should be identified in early pregnancy, and hence first trimester screening for preeclampsia and FGR is absolutely mandatory for every patient so as not to miss the opportune window for starting ecosprin before 16 weeks. And so it's 150 milligram per day. This is Esprit trial, and it should be started in the first trimester at 12 weeks to be finished at 36 weeks, and it is to be taken at bedtime when it lowers the risk of preeclampsia, FGR, preterm birth, and IUDs. The effect is best when it is taken at night because absorption is better. It has a better bioavailability, better morning BB control, and it better attenuates morning platelet reactivity when ecosprin is taken at night. And the Esprit trial also indicates that prevention by ecosprin is of the order of 80% for early onset preeclampsia and 62% for preterm preeclampsia. And this percentage even goes higher if the compliance of ecosprin is good. So we have detected 80% of high-risk cases by our screening, and by giving aspirin to them, we have prevention. We can achieve prevention of 80% of the patients before 34 weeks. And how does aspirin prevent preeclampsia? It delays the development of preeclampsia. So if it was destined to happen at 28 weeks, with aspirin, preeclampsia would now happen at 36 weeks. So a delay of 6 to 8 weeks by aspirin can be achieved. So if preeclampsia was destined to happen at 34 weeks, it would happen at 40 weeks, and patient would deliver before 40 weeks. So preeclampsia will not happen.
रूबी, आपको 26 वीक्स पे मैंने बुलाया था, आप फिर 3 वीक्स लेट आए हैं, आज तो आपका 29 वीक्स हो गया बाय डेट्स। मैं आपका अल्ट्रासाउंड करती हूँ, पर मैं कलर अल्ट्रासाउंड करूंगी। आपके प्रिस्क्रिप्शन पे नॉर्मल ग्रोथ स्कैन लिखा है, पर हम लोग कलर डॉपलर करने जा रहे हैं आपका।
मैम मेरी डॉक्टर ने तो मुझे नॉर्मल अल्ट्रासाउंड के लिए कहा था।
बेटा नॉर्मल के लिए कहा था, पर जो 3rd ट्राइमेस्टर का अल्ट्रासाउंड होता है 28 हफ्ते के बाद, कोई भी अल्ट्रासाउंड वो कलर में ही होना चाहिए। इसी से पता लगेगा कि बच्चे को कैसा ब्लड फ्लो जा रहा है, ठीक है। तो बच्चे के बॉडी पार्ट्स में, सारे ब्रेन में, सब में कैसे फ्लो जा रहा है, आपके प्लेजेंटा से बच्चे को कैसा फ्लो जा रहा है, और आप से प्लेजेंटा को कैसा फ्लो जा रहा है, ये सारी चीजें कलर डॉपलर से ही पता लगती है।
डॉक्टर मैम कॉस्ट भी थोड़ी ज्यादा है,
तो थोड़ा सा मैं आपको डिस्काउंट कर देती हूँ इसके ऊपर कलर डॉपलर पे, ठीक है।
मैं अपनी डॉक्टर से कंसल्ट करके फिर आपको बताती हूँ।
अच्छा, आप फोन करना चाहोगे उन्हें?
हाँ जी,
ठीक है, आप फोन कर लीजिए और फिर आप रिसेप्शन में बता दीजिए। जी ठीक है। Hi, Dr. Vandana.
Hello, Dr. Kavita. How are you?
Yeah, all good here.
Dr. Kavita, I've called you regarding patient Ruby. What is the need of doing color Doppler at now 29 weeks? She hasn't come to you at 26 weeks. Growth and movements appear fine. So better we do this time only growth scan and color Doppler in the next scan. She is not very affording.
Yeah, in fact, she came to me at 29 weeks and 4 days. Last we talked, we decided we will see her at 26 weeks, and I think you also asked her to come to me at 26 weeks, but she came to me at 29 weeks today. So regarding color Doppler, now the new protocols that we are following, the Samrakshan and FMF and Barcelona protocol, they all suggest that all ultrasounds, all growth scans in the 8th and the 9th month, that is after 28 weeks, they should be color Dopplers. And this is so that we catch these babies, the growth restricted babies very early, and we can stage growth restriction, and we know when to call them again, when to follow them again. So for all this we need color Dopplers. And like you said, the weight appears, the growth appears to be normal. So now we have this AGA babies, where if the Doppler is abnormal, we call them FGR in AGA.
Okay.
Yeah. So AGA is appropriate for gestational age baby.
AGA is approximate for gestational age. Okay.
Yes, appropriate for gestational age babies, where the weight will be more than 10 centile. So even you would not, expect that there is anything abnormal, because to look at it might appear normal. But on doing Dopplers could be abnormal. So to catch these babies which are FGR in AGA, we have no other way than to do a Doppler, because even these babies require close surveillance. And in last pregnancy, she developed abnormal Dopplers and FGR at 28 weeks. So definitely at 29 weeks, 4 days today, I will like to do a Doppler and not a simple growth scan. In any case, Dopplers have to be done, and even in subsequent scans, Dr. Vanna, all the scans I will do Dopplers along with biophysical profile, because we need to know what is the right time of delivery. Okay. Yeah, we don't want to deliver these patients too premature, or we don't want to wait too long for the fear of hypoxia. So the answer is to do Dopplers and biophysical profile in all scans which I do after 30 weeks now for her.
Okay, you proceed with the growth scan as well as color Doppler. I will guide patient accordingly.
Now, the scan was done at 29 weeks and 4 days. Patient reported 10 weeks after previous scan, which was done at 19 weeks. Patient was on ecosprin 150 milligram now, taking it at bedtime. Blood pressure had increased. It is 150 by 90. There was no urine protein. LFT, KFT was normal. GA by ultrasound was 27 weeks. So there was a lag of 2 weeks and 4 days at this scan, and the Liker was less, AFI was 8. By biometry, abdominal circumference was less than 3 centile. So earlier it was 38 centile at 19 weeks, and now it is less than 3. So it fell in the category of FGR stage 1 by biometry. As for the color Dopplers, only uterine artery BI was high. This was more than 99 centile. So it is early onset FGR stage 1, and follow-up was advised after 7 days. It's important to ask the patient to keep a tab on daily fetal kick count, which we know is a component of NST and biophysical profile and CTG as well. And this would tell us about the neurological intactness of the baby, and also guide surveillance. So it's absolutely important to look at the daily fetal count as well. And we are all familiar with this Delphi consensus definition of early and late onset FGR. And this particular patient, AC and weight was less, the AC was less than 3 centile, and uterine artery more than 95th centile. And this was early onset FGR. As for the staging by Barcelona protocol, we know that the stage 1 has these Doppler changes. It's mild placental insufficiency, and this patient had uterine artery Doppler abnormality. All other Dopplers were normal, and this was stage 1 FGR. Anything else that we could do to anticipate preeclampsia? We could do the biochemical screening in the 2nd and 3rd trimester. It is SFLT and PLGF. We know PLGF decreases and SFLT increases, and the ratio is elevated 2 to 5 weeks before clinical onset of preeclampsia. And if the ratio is less than 38, if the ratio is less than 38, it is reassuring. It predicts short-term absence of preeclampsia within a week. This patient could not afford biochemical screening, so I did ophthalmic artery Doppler for her. Ophthalmic artery is the first branch of internal carotid artery. It has embryological, anatomic, and functional similarities with intracranial vasculature. Doppler assessment provides information on the less accessible intracranial circulation. In pregnancies with preeclampsia, there is decrease in PI and increase in velocities in the intracranial circulation. So ophthalmic artery is an objective technique which is used for detection of all types of preeclampsia. And the changes in ophthalmic artery are due to maternal hemodynamic adaptation to pregnancy and not due to trophoblastic invasion. So even uterine artery may be normal in some cases because it is not dependent on trophoblastic invasion. Uterine artery may be normal, and ophthalmic artery may be suggestive of preeclampsia setting in. I'll not go into the details of technique. The patient is in supine position, eyes closed, gel applied on upper lid, and with linear transducer, we interrogate the ophthalmic artery 15 millimeter from the optic disc and medial to the optic nerve, and that is the waveform. And the indices which should be recorded are peak systolic velocity, first diastolic peak velocity, which are important. PI can be measured, and the ratio, the most important parameter, is the ratio of first diastolic peak upon peak systolic velocity. This PSV ratio is significantly increased in preeclampsia, and this very patient, the velocity of the first diastolic peak was increased. So this was abnormal, and the peak velocity ratio was also increased. PI, we know it is decreased in preeclampsia, and so it was in this case, in this patient. So all the 3 parameters were abnormal, which predicted early onset preeclampsia, so the prediction of preterm preeclampsia, ophthalmic artery has a great detection rate. It increases the detection rate by almost 9%, 8 to 9%. So we had 80% detection rate by maternal factors, mean arterial pressure, and uterine artery PI, and it goes to 88% once ophthalmic artery PSV ratio is added to this. So ophthalmic artery is helpful for short-term prediction of preeclampsia within 3 weeks.
तो रूबी आप आज मेरे पास आए हैं 29 वीक्स 4 डेज पर, ठीक है। इससे पहले मैंने आपको 10 वीक्स पहले यानी कि 19 वीक्स पे देखा था और आपको 26 वीक्स पे आने को कहा था, बट समहाउ आप शायद नहीं आ पाए। तो आज 29 वीक्स 4 डेज पर आपका बेबी कमजोर है, ग्रोथ रिस्ट्रिक्टेड है और 27 वीक्स का आ रहा है, यानी कि देयर इज अ लैग ऑफ 18 डेज, ठीक है। और लाइकर जो पानी होता है बच्चे के आसपास वो भी कम है और आपका कलर डॉपलर भी एबनॉर्मल है। और मैंने आपका ऑप्थेल्मिक आर्टरी डॉपलर जो आंखों का अल्ट्रासाउंड किया वो ब्रेन सर्कुलेशन देखने के लिए किया और वो भी सजेस्टिव है कि आपको आने वाले 3 वीक्स में प्री-एक्लेम्सिया होने का चांसेस हैं। ओके, सो यू हैव टू बी वेरी केयरफुल। आपका ब्लड प्रेशर तो 3rd मंथ से ज्यादा चल ही रहा है ना। 3rd मंथ पे ज्यादा था, 5th मंथ पे हमने देखा तो ज्यादा था, बट इट वाज अराउंड 138/90। आज आपका बीपी है 150/90। So far you are not taking any antihypertensive. You are only on salt restriction. You can ask your gynecologist if she will like to start some antihypertensive for you. तो आज जो आपका डायग्नोसिस है वो है अर्ली ऑनसेट FGR, ग्रोथ रिस्ट्रिक्शन स्टेज 1। आपको रूबी ध्यान रखना है ब्लड प्रेशर का। एवरी डे यू मस्ट मॉनिटर योर ब्लड प्रेशर। कुछ ब्लड टेस्ट जैसे कि KFT, LFT, प्लेटलेट काउंट्स, ठीक है, यूरिन प्रोटीन, ये सब आपके होने चाहिए। आप अपने गायनेकोलॉजिस्ट से पूछ सकते हैं, ओके। और साइंस एंड सिम्टम्स ऑफ प्री-एक्लेम्सिया मैंने आपको लास्ट टाइम बताया था, आपको उन सबका ध्यान रखना है। डेली फीटल किक काउंट यानी कि बच्चे का मूवमेंट का आपको बहुत ध्यान रखना है, ओके। सो ये सब आप ध्यान रखिए और आप मेरे पास अब आएंगे आफ्टर 1 वीक for next ultrasound. So please remember you have to come to me after 1 week. Daily fetal kick count और ये blood tests आपने बीच में कराने हैं, ठीक है।
Gynae was informed about the report and antihypertensives were started at this time, that is at 29 weeks and 4 days. And patient was advised follow-up after 1 week with ultrasound report. Nevertheless, patient reports to radiologist after 12 days. So after 12 days, blood pressure was 150/110, urine protein was 3+, LFT shows hypoproteinemia. Patient had edema feet and headache. And on ultrasound, there was a lag of 3 weeks and 2 days. So GA by ultrasound was 28 weeks, but the patient was 31 weeks and 2 days. Liker was less, AFI was 8, and fetal movements were less. Biometry had fallen down, so all the parameters were 1 to 2 percentile. AC from 3 centile, it is 2 centile now, and the weight, which was at 5 centile at 29 weeks, it is at less than 3 centile now. The Dopplers have deteriorated, and umbilical artery, which was 30th centile at 29 weeks, it is at 90th centile. Uterine artery was already 99 centile. MCA, the resistance has decreased from 25% to 8%, and CPR from 41% to 3%, and it is still stage 1 FGR. Now, the patient was counseled by the radiologist that she has developed pre-eclampsia superimposed over chronic hypertension. She was explained that BP in pregnancy accelerates very rapidly and may be unresponsive to treatment when a mother is developing preeclampsia, as has happened in her case. It places the mother at risk for seizures, stroke, heart failure, renal and liver failure. It places the baby at risk for poor growth, stillbirth, IUD because of placental abruption and heavy bleeding. Hospital admission was suggested to her and close monitoring for blood pressure, proteinuria, LFT, KFT, and platelet counts in the hospital. And she was asked to watch for signs and symptoms of preeclampsia. At the same time, delivery may be done for maternal indication. This message was given to her. And although for the fetus, we could have waited and scanned for after 1 week because it was still stage 1 FGR as far as fetus was concerned. And all this information was given to the gynecologist. The patient was hospitalized and delivered a day later, that is at 31 weeks and 3 days. Indication was preeclampsia and deteriorating maternal condition. Urine albumin was 4+ the next day. That is the day of delivery. Blood pressure was 180 by 110 on the day of delivery. Cesarean was done and the baby weight was 1 kg and 140 grams. Baby was in NICU for 27 days. Baby weight at discharge was 1.9 kg. Mother was not in ICU. Maternal condition remained stable. Today, that is on the 1st of June 2023, baby is 2 months and a half old. Baby's active weight is 3 kg and 200 grams, and mother's blood pressure normalized in 10 days after delivery, and she's off antihypertensives now. So if the maternal condition is deteriorating and BP is not responding to treatment, or if there's imminent signs of preeclampsia, deliver irrespective of fetal condition. So just a couple of slides on preeclampsia. We know it is gestational hypertension, that is hypertension happening after 20 weeks with one or more than one of the following new onset conditions at or after 20 weeks. And these new onset conditions are proteinuria and other mother or other maternal organ dysfunction like kidney, liver, neurological involvement or hematological complications. And we have complications of preeclampsia during pregnancy related to maternal organs, and the fetal complications are FGR, premature delivery, abruption, abruptio placentae, and fetal demise. Ongoing risk, this is a very important complication of preeclampsia, which is ongoing risk after delivery in the mother. It is hypertension, IHD, and cerebrovascular accidents or stroke. In these babies who are delivered to the preeclamptic mothers, the complications are developmental delay, obesity, hypertension, cardiovascular disease, and metabolic syndrome. And this is the timeline for cardiovascular risk in the mothers who have had preeclampsia and pregnancy. Short-term complications are hypertension and heart failure, and diabetes and dyslipidemia. And long-term complications which happen after 10 years are coronary artery disease and cerebrovascular disease or stroke. And it could eventually result in cardiovascular-related death. So the heart factors, women who develop preeclampsia are 5 times more likely to develop heart disease or stroke in the subsequent 20 to 30 years. And 2 out of 3 women who develop preeclampsia and pregnancy die of heart disease. So coming back to this case, we know the patient deteriorated from 29.4 weeks to 31.2, there was sudden fall of biometry and the Dopplers as well. Now, World Organization Gestosis recommends that systolic BP of more than 140 and diastolic BP of more than 90 warrants antihypertensive therapy. Target range of blood pressure should be less than 140 by 90. So could we have managed this patient better? The lacunae in the present case were first trimester screening was not done and preeclampsia was not predicted in the first trimester, and gynecologist and the patient were not alerted. Had first trimester screening been done and had ecosprin started in the first trimester, onset of preeclampsia could have been delayed. We have seen that the preeclampsia, the onset could be delayed by 6 to 8 weeks by ecosprin. So here, the onset of preeclampsia could have been delayed and thereby prolonging the pregnancy beyond 32 weeks, which is the cutoff for lung maturity, and NICU stay could have been decreased. Ecosprin was taken in inadequate dose, 75 milligram, until 20 weeks instead of recommended 150 milligram. That was another lacunae, and it was being taken at the wrong time, morning instead of night. The second trimester screening that we did was we did preeclampsia assessment at that time, and preeclampsia was predicted. Dose of ecosprin was increased to 150 milligram. So probably this 150 milligram from 20 weeks and the low dose which was given to the patient by the gynecologist right from 8 weeks had some effect, and it probably helped combat preeclampsia till 31 weeks. Else, who knows, preeclampsia could have developed even earlier. About surveillance, despite repeated counseling, patient had a poor follow-up with the gynecologist. As a result, her close surveillance for blood pressure and proteinuria could not be done, and antihypertensives were initiated late. Having said that, we should be aware that ecosprin is less effective in a case of chronic hypertension complicated by preeclampsia, as happened in index case. So stringent monitoring and surveillance should be maintained even when patient is on ecosprin. So there were there were many factors in this particular case which resulted in a premature delivery before 32 weeks at 31 weeks and 3 days, and which resulted in a long NICU stay for this patient. So the messages are: dating and correction of LMP and EDD should be done right in the first trimester, and once corrected, it shouldn't be changed in the pregnancy. NT-scan should be inclusive of preeclampsia and FGR screening. Ecosprin is a wonder drug, and 150 milligram ecosprin should be started for all those at high risk, more than 1 in 150 by FMF and Samrakshan protocol. It should be started before 16 weeks, and compliance is of utmost importance because optimal benefit of 80% by ecosprin is only when compliance is good. Preeclampsia screening at anomaly scan guides surveillance. Don't stop ecosprin if uterine artery normalizes or second trimester screening is a low risk. All growth scans after 28 weeks should be inclusive of color Doppler and assess follow-up by Barcelona protocol. Daily fetal kick count is important in between Dopplers. For hypertensive mothers, close monitoring by blood pressure, proteinuria, LFT, KFT, platelet counts, and signs and symptoms of preeclampsia should be done. Delivery is done for fetal or for maternal indication like preeclampsia. Looking at long-term complications of preeclampsia, these patients should be monitored in postnatal period for their cardiac and metabolic health. Now, all stakeholders, obstetricians, radiologists, neonatologists, and fetal medicine specialists should come together for optimal pregnancy outcome, which is the aim of Samrakshan, founded by Dr. Rijo Matthew, which aims to reduce perinatal mortality in India by first trimester screening for preeclampsia, initiation of ecosprin for all those who are at high risk, and second and third trimester Dopplers, and management by protocols. And the results of implementation of Samrakshan has been phenomenal. So this is a paper published by Samrakshan in IJRI about impact on India in the 2-year period. So the districts which followed Samrakshan protocols, preeclampsia and FGR was reduced to 1/3 and preterm birth reduced to 1/2. And the vision and the mission of this movement, now we call it the Movement of Radiologists of India, is to scale Samrakshan to all 757 districts of India, to reduce pre-eclampsia to less than 3% from current 8 to 10%, and FGR to less than 10% from current 30 to 40%, because safe motherhood is the right of every woman. Let's see what happened behind the screens.
Thank you, doctor. आपने मेरा इतने अच्छे से
अल्ट्रासाउंड
स्टार्ट बोल दिया तो
स्टार्ट
इतना जोर से नहीं बोलना।
मैम वो तो कर गई।
Hi, Dr. Vanna. So nice to hear from you. In fact, I was about to call you. There are very few reference from you for the past few.
तुम क्वेश्चन पूछो।
अभी आपका बेबी कैसा है?
अभी बेबी मेरा इस डॉक्टर अभी बेबी मेरा बिल्कुल ठीक है, 3 साल का है।
हाँ वन्ना।
Hi, Dr. Kavita, Dr. Vanna here. Huh?
Hi, Dr. Vanna. Nice to hear. अच्छा वन्ना, हमें ये रिकॉर्डिंग करनी है, तो हम इसे दोबारा करेंगे।
ठीक है, तभी तो मैं तो उसी तरह बोल रहा था। हाँ, भेज दिया मैंने पेशेंट को बाहर बैठा दिया।
भेज दिया ना?
हाँ।
तो नेक्स्ट पेशेंट
मैम नेक्स्ट पेशेंट डॉक्टर रूबी। सॉरी
ठीक है, फिर क्या कहूँगी? नहीं, बस एक जाना पड़ेगा।
I'm grateful to Dr. Vandana Savalka, my protagonist, and my Samrakshan task force, my clinic staff, Sangeeta, Shivani, Simran, and Fazil. They made a lot of efforts to put this together today. Thank you very much.